Hi everyone, so we are starting off our fetal anomalies with this module. So up until this point, we have learned all about what is normal in terms of baby development and also the extrafetal organs and structures. So we've learned about normal first trimester, second trimester development. We've learned about the placenta, normal cervix, normal fluid. So we want to make sure that although we know what is normal and what normal looks like, we're looking for any variations to that. And it's extremely important in OB that we look for those fine details. Those of you who have come in for a quick OB demonstration, you were able to see how difficult imaging the brain actually is and getting to the particular level that you need to get at in terms of obtaining your measurements and looking at those specific structures that develop in the brain. So it's going to be even harder when we're looking at something that is not going to fall within those normal categories. So we're going to be starting off our fetal abnormalities with our cranium. So our head, we have a lot of deformities that can happen for an array of different reasons. And then we're also going to be talking about going hand in hand with the cranium, also the spinal cord and some of those abnormalities as well. So we're going to start off with our head. Now, talking about the cranium in and of itself, when we say the cranium, we're talking about the cranial bones. We're not really talking about the kind of like the inside material or the functioning tissues of the brain itself. So one of the things that can happen with the actual cranial bones is that we can have deformities with how they fuse. And this gives us sort of a context or a preface into something that could be a bigger problem down the road. So we want to see a nice kind of elongated, oval, pretty proportional skull in a baby. We can anticipate to see some of those spaces as those sutures develop with the baby's different cranial bones. But anytime we see an abnormal shape, we're going to question if they have craniosynostosis. And what this is those bones actually close, those cranial sutures close earlier than they should. And it kind of creates this like abnormally shaped skull. One of the more common shapes with craniosynostosis is going to be the cloverleaf skull. Now it kind of has this like scalloped or this buckling type of appearance to it. And although craniosynostosis can be its own isolated finding, we're usually going to see cloverleaf skulls with other sort of chromosomal or genetic abnormalities. So if we happen to see an abnormally shaped skull, we don't want to just leave it at that. We want to say, okay, what else is going on with this baby so that we can have the best and most accurate diagnosis. So here's a classic appearance of what that cloverleaf skull is going to look like. You can see those cranial bones, especially the parietal bones on the side, really forced to kind of close and kind of come in a lot earlier than they should have. So it's giving us this very kind of lobular sort of appearance. Of course, that's going to lead to some problems in terms of cognitive function because we're now kind of compressing the space that the brain has to develop and function. So although it can be an isolated finding, it is going to precede some other conditions that we need to be aware of. So next we have acrania, and then we also have anencephaly. So these are two very common conditions that we see with baby skulls in the OB world, and it's extremely sad. Acrania tends to be a little bit better of a prognosis than anencephaly is, but both of them are very serious and usually not going to be compatible with life, at least for any sort of extended period of time. So acrania, anytime we see that prefix A, we know that something is missing. So we're actually going to be missing part of our cranium. So some of our cranial bones are just not even going to develop at all. So this is something that we actually can see prior to the diagnosis of anencephaly. Anencephaly is when we don't have any development of the brain tissue. So if we see a baby that maybe isn't developing their skull, we want to question, okay, do they even have brain matter within that, what would have been that skull? So acrania, we don't have the normal cranial bones that we should. On ultrasound, this is going to be known as our Mickey Mouse head or Mickey Mouse sign. We can see this as early as 12 weeks. Remember, those bones are going to start to develop really early on. Ossification happens very early. So we're not going to be able to see any of those cranial bones in that baby's head like we should. So here we have two pictures of the crania. Of course, the image on the left-hand side is going to be a little bit further of a gestational age. Picture on the right-hand side, pretty early gestation. You can see that we almost have sort of like this horn that's coming off in both of these babies, and that's because they have brain matter, they have brain parenchyma, but they don't have any of the cranial bones to contain it. So it's kind of like this free floating brain tissue. You know, and of course, when you think of it that way, it's not going to be something that we kind of just treat as normal. And we don't really expect the baby to make it to term and kind of survive delivery and life shortly thereafter. But although these babies do have a pretty poor prognosis, it is going to be slightly better than anencephaly because they do at least have functioning brain parenchyma. They just don't have the supportive structure of the skull to contain it all. So anencephaly, what is this? This is actually going to be the most common neural tube defect. We see this in about 1 out of every 1,000 pregnancies. It's a congenital absence of the actual brain parenchyma, so we don't have really any sort of cranial formation at all. If we do happen to see a little bit of tissue development, we may see some cerebral tissue, but it's not going to be functioning. We're not going to have functional brain parenchyma at all. On ultrasound, we can again see this very early on. We are going to see basically a missing sort of skull, of course, because we're going to have acrania with anencephaly. We're not going to see any sort of brain tissue developing in that region. And sometimes the baby's face can look very prominent. So they develop the neck, they develop a face, but they don't develop any brain or cranial tissue. So we can kind of see like this frog-like appearance of the baby's face, and that's going to be something that can help you to differentiate that. So image on the right-hand side, this is that coronal slice of the baby's face. You can sort of see the orbits are pretty abnormal looking, but they're pretty prominent as well. So they do have some facial structures that had developed. We do see a tiny bit of cerebral tissue here coming off of the base of the baby's head, but again, we're not seeing any sort of cranial bones. We're not seeing any sort of normal looking brain parenchyma. Now on this baby on the left-hand side, again, we kind of see a stump at the end of the spinal cord where maybe the baby's head would further develop, but we see a little bit of face structures here, slightly abnormal in their development as well, but we don't see anything above that where the brain should be. Next, we have cephaloceles, also known as encephaloceles. Either term is acceptable. These are known as another sort of cranial defect, so an abnormality with the development of the bones. So basically, our bone had some sort of separation when it should have fused. So craniosynostosis is they fused too early, and now we have something where maybe they didn't fuse properly or they didn't fuse enough, and we have sort of this opening between these cranial bones. When we have that opening, it allows for herniation, right? So it allows for all of that material to kind of travel through and poke out of the baby's head. So when we have a cephalocele, we're going to have that herniation of brain parenchyma, and also the meninges from the spinal cord can come out as well. Now, depending on which hemisphere of the world we live in, we do have different sort of prevalences to these types of conditions. If we are on the Western hemisphere, which we are usually going to see these cephaloceles coming off the back of the baby's head. If we are in the Eastern hemisphere, we see a lot of babies having these cephaloceles coming out through the frontal aspect of their head. We can have these herniations really anywhere because remember, we have all of those sutures between all of those different cranial bones. So we can have them at any space where that is occurring, where they should be fusing. We can have this herniation in this opening pretty much anywhere. So we can have these in the front, we can have them in the back, we can have them nearby the eyes in the nasal region. We can have these along the side near the baby's temple with the parietal bones. But typically, we're going to see these either in the back of the baby's head with the occipital bone, or in the front of the baby's head with the frontal bone. Now on ultrasound, whether it be an occipital or a frontal, it's pretty much going to look the same. We're going to see this kind of like rounded cystic-like mass protruding from the skull. Depending on what content has herniated through, that's going to change the internal appearance of what this mass is going to look like. So if we basically just have the meninges coming through, where we have a lot of that cerebral spinal fluid coming through, it's going to look a little bit more cystic. So we're going to see it a little bit more anechoic. We're not going to see as much echogenicity going on within that cystic kind of mass. Now, if we have a lot of brain parenchyma coming through, this is where it's going to start to appear solid. So if we are more concerned for the brain parenchyma itself, we're going to tend to lean towards calling that an encephalocele. If we have the brain parenchyma and the meninges, we can really use either term. And if we have just the meninges coming through, we're going to consider that a meningocele. We're going to kind of come back to the term meningocele at the end of this PowerPoint, but kind of continuing on with that train here, when we just see oh, here we have a picture of what that solid brain matter would look like. So that classic encephalocele, we can see that that is coming off of the occipital region of the baby's head. So this is going to be of a Western prevalence. You can see we have this cystic region here. So that's probably going to represent some cerebral spinal fluid from the meninges. And then we also have this echogenic brain matter or parenchyma coming through. So now a meningocele, like we said, is when we just see that herniation of the meninges coming through. It's going to look a little bit more cystic coming out, and that's exactly what we have here. So again, pretty obvious protrusion, but a lot more cystic than that first one. So kind of that classic meningocele appearance. Now we will come back to meningocele and kind of the variations of what a meningocele can be if we're talking about just the spinal cord towards the end of this PowerPoint. So sticking with the brain here, sticking with the head, we have hydrocephalus. This is also known as ventriculomegaly. There is a little bit of difference between the two, although again, they do kind of use the words interchangeably. We're using the term hydrocephalus as a little bit more of a definitive diagnosis, whereas ventriculomegaly is really kind of just saying that we have the enlargement of our ventricle or ventricles. So this is going to represent the dilation of the ventricular system without our head getting bigger. Okay, so when we have ventriculomegaly, we're just saying, hey, our ventricles are enlarged for some reason, but it's not having an effect on our actual skull. Now, when we have that ventriculomegaly, we have that dilation of the ventricular system, and our head starts to get larger, that's when we're going to term that hydrocephalus. So that's going to be a little bit more of a definitive diagnosis. Kind of hard for us to diagnose that on ultrasound unless this baby's head is just like absolutely gigantic. But if we kind of have like mild ventriculomegaly, maybe the baby's head's measuring a little bit bigger than the rest of the gestational age, it's going to be hard for us to definitively say, okay, now this baby falls into the hydrocephalus category. But some babies do have really, really severe dilation, and of course the skull has to accommodate for all of that extra fluid. So it's going to start to expand and enlarge. We can sometimes see this at the end of the first trimester, but we're usually going to see this more so in that second trimester. On ultrasound, we're going to see that enlargement of the ventricular system typically in the lateral ventricles. As we know, that's where a lot of our cerebral spinal fluid is going to be produced. So we're going to see that in the lateral and the third ventricle, because we know the third ventricle is going to come right from the lateral ventricles. We only can classify ventriculomegaly when that lateral ventricle AP diameter exceeds 10 millimeters. So we want to make sure that we are getting a precise measurement. We want to make sure that we are going in a perfect axial to that baby's skull so that we're not elongating or shortening that AP measurement. We also can still see that choroid plexus in that dilated lateral ventricle. Remember, as that baby develops, the choroid plexus is going to occupy less and less space of that ventricle. But if we're talking about a condition of ventricular enlargement, that choroid plexus is going to look even smaller. So what is this going to look like? This is a very, very severe case. So basically these lateral ventricles are so dilated that there really isn't any room for the normal brain parenchyma to develop and function. So these are, this baby is most likely going to fall into the hydrocephalus category. We don't have any of the other measurements. We don't have any of the gestational age information, but when we have our ventriculomegaly this severe, there's really not going to be any sort of circumstance where the baby wouldn't have hydrocephalus. And if we look really closely, we can kind of question if this is still a choroid plexus going on, but again, not 100% sure. Next, we have holoprosencephaly. So your registry will love to ask you questions about this. This goes back to very primitive development of the baby in terms of embryology. When we talked about fetal development, we talked a lot about, the dermal layers, right? The germ layers. We talked about the mesoderm, the ectoderm, all of those basic terms, right? We talked about the hindgut, the midgut, the foregut. This is going to be talking about those primitive layers and sections of the baby's head and spinal cord development, so the central nervous system development. Now, when we have the baby's very primitive head development, we have all of these different cephalons. That's kind of like the root word that they like to use. They have like the mesoencephalon, they have the prosencephalon, they have the rhombencephalon. So depending on where in that brain development we are looking or we're questioning, is going to have different sort of anomalies that will follow that section when the baby is developing. Now, one of the things that you may actually be able to see in a very early first trimester ultrasound is the rhombencephalon. If you've done a first trimester ultrasound, you may have seen, and say you have you're working on a beautiful machine, you should have definitely seen a rhombencephalon. So here we have our little bean, right? So you've got like an 8-weeker, 7, 8, 9-weeker. You may have seen that baby. You're like, okay, cool, I got a crown rump length, beautiful. And then you may have seen the back of the baby's head. You may have seen like a perfectly cystic area. That's going to be your rhombencephalon. That's actually a good sign that we want to see in the first trimester ultrasound, because it means that all of these encephalons are developing and they're differentiating at that point. So if you ever see that cystic, small posterior region of the baby's head in a very early ultrasound, that's going to be your rhombencephalon, and that's going to be a good sign that the brain is developing the way that it should. So moving away from the rhombencephalon, we're now talking about a different section. This is called the prosencephalon. So basically during all of this, I don't want to get all into like the cellular level of the baby's brain development, but basically this section of that primitive brain failed to separate into cerebral hemispheres and individual lateral ventricles. So we basically said that when we had this pretty primitive brain structure with all of our encephalon sections, it didn't continue to split. We want to see that split in the brain, right? We want to see that split. We also want to see the connections in the correct areas. We want to see the falx cerebri. We want to see the corpus callosum. We want to see all of those things. We want to see the callosal fissure. All of those structures that we see in that second trimester ultrasound tell us that the baby's brain split at the prosencephalon when it should have in early pregnancy. Okay, so this is something that's going to happen very, very early on in pregnancy, but we're not going to be able to see it until the second trimester. So depending on how it failed to split, it could be either a partial or a complete failure to split. Now, of course, if we think about which one's going to be more serious or more complicated, it's going to be the one where we had a complete failure of those cerebral tissues and the lateral ventricles to split. So that's going to be our alobar type of category. So alobar, what's that saying? We don't have lobar anatomy, right? We don't have the right lobe of the cerebral tissue. We don't have the right, did I say right? Whatever. We don't have the right and left lobes of the cerebral tissue. We don't have the right and left lateral ventricles. So we just have one. Right? So we're going to have a single ventricle. We're going to have a very small cerebral tissue that is kind of all kind of clumped together in one. We're going to have a fused thalamus. Our thalamus is not going to be that beautiful butterfly shape on both sides of that falx. We're going to have the lack of the corpus callosum, and we're not going to see the falx cerebri, because the falx cerebri is what we can say, if we see it, yeah, this all split, okay? The corpus callosum, that's going to be like, okay, yep, I split, but I'm still connected, so you can still communicate at that posterior aspect of the cerebral tissue. Well, if you didn't split, then you don't need a corpus callosum for communication. So alobar is really just like, we got pretty much like one of everything, and we don't have the structures that we need to be able to say, yes, this tissue split. On ultrasound, this brain tissue is going to look very abnormal depending on the category that it falls into. We're going to see all of those characteristics of alobar holoprosencephaly. We're going to see some facial dysmorphism, and before 9 weeks, we can't really tell what this is, because it's normal to not be able to differentiate that brain tissue. It's normal to kind of see a single ventricle. It's normal to see a rhombencephalon, right? And the rhombencephalon, what we think could be the rhombencephalon, could actually be this holoprosencephaly starting to slowly show itself. But chances are, most likely, it's just going to be a normal rhombencephalon. So before 9 weeks, we're not able to see any sort of indication that this could be happening. Definitely going to be more of a second trimester finding. So here we have our two categories. Now, we can have alobar, lobar, and semilobar. Semilobar, I, for the life of me, cannot really find a good image of semilobar. But basically, our two pictures on the left-hand side are going to represent alobar holoprosencephaly, and then we have lobar on the right-hand side. Now, if you look at alobar versus lobar, the lobar kind of has like this heart shape to it, right? So this is kind of saying like, all right, I tried to split, right? I tried to differentiate. I tried to give you two hemispheres, but I just couldn't get there. So that's going to be our partial failure to differentiate, or our partial failure to split. Now, if you look at our alobar, I mean, all of this parenchyma is all fused together. We see a single ventricle, right, on both images. We're not really seeing any definitive cerebral tissue that has developed properly. So alobar definitely going to be more serious, and we're really kind of just going to see one of everything in that baby's axial brain. Next, we have hydranencephaly. So this is going to be when we have an arterial occlusion in the carotid arteries of the baby. We know our carotids are responsible for bringing blood supply, oxygen-rich blood to the brain, right? And that's no different for the baby. So for some reason, the baby has occluded carotids. So the baby is not getting any oxygen-rich blood to the brain at all. Because of that, we know that tissue starts to die. So the brain tissue is going to die off, and in replacement of that brain tissue, our choroid plexus is going to kind of like keep working, and we're going to just keep producing cerebral spinal fluid. We're not going to have any sort of normal brain tissue. We're not going to have any functioning brain tissue, because it all died off from the occlusion in those babies' carotids. So we're going to see this really fluid-filled skull. This is going to be kind of just a random event that happens. This is not something that is genetically linked. This is not a chromosomal abnormality. This is extremely rare. And usually the occlusion in the baby's carotids is going to be caused by some sort of maternal infection that crossed through to the baby. Anytime the baby has any sort of exposure to an infection or a virus, that plays a really big effect on the baby's cardiovascular system. So they could have formed hypercoagulability in response to that infection. They could have formed thrombus somewhere that embolized up in the in the carotids, particularly the ICAs. So this is something that is really unpredictable. There's not really anything that anyone can do about it. And because we keep producing so much fluid and we can't really filter out that fluid as much as we would like to, we are also going to see this with polyhydramnios. So we are going to see this with excessive fluid levels in the baby's gestational sac. So what is this going to look like? Fluid-filled cranial vault. Really no, if you look on that MRI picture on the left-hand side, we have the brainstem, we have the cerebellum, posterior head, we don't have any cerebral tissue because it just was not getting any blood supply from those ICAs. So all of this is where the baby's cerebral tissue would be. If you look at this baby's head, it looks massively enlarged, right? So the baby's skull had to enlarge to accommodate all of that fluid. Now this is different than ventriculomegaly, right? Because ventriculomegaly, we still have that cerebral tissue that wants to function. It's still getting blood supply to it, but for some reason, the ventricular system is dilated. So we just get all of this fluid. In this case, hydranencephaly, we have replacement of that brain tissue because the brain tissue is dead because it didn't get any blood supply from the carotids. So now it's being replaced with the cerebral spinal fluid. So don't be confused if you get a picture of this on your registry. Look for your context clues. Look at what the question is asking you. These pictures may look the same on ultrasound, but you need to look at what other information they're giving you. Next, we have microcephaly. So this is really just an abnormally small head. We typically only will categorize a baby with microcephaly if their head size falls very standard deviations below the average. So really, if that head is tracking significantly smaller than the average baby's head, that's when we fall into microcephaly. Now, of course, anytime we have a smaller than average head, that's going to not allow the appropriate space for the brain tissue to function and develop, right? So we're going to have reduced brain size. We're going to be seeing some sort of neurologic deficits in those babies. We're going to see some sort of developmental delays in those babies just because their brain tissue can't function the way that it wants to. Now, this can be an isolated finding, just like craniosynostosis can. It can be just an isolated finding, but usually we're going to see it associated with something else. So there's going to be some sort of genetic reason or chromosomal reason that this baby has something that it didn't allow their head to develop the way that it should have. So a lot of our trisomy that we're going to learn about in a few weeks, a lot of our chromosomal conditions that we're going to learn about, they don't just represent one ultrasound finding, right? We see like 10 findings. We see 10 conditions, give or take, with these conditions or with these diagnoses. So microcephaly is a very common one that we see as a byproduct of a larger problem going on. Here we have normal baby size head, left-hand side. Baby with microcephaly right in the middle. You can see kind of the back of the head is becomes flattened, and then severe microcephaly on the right-hand side. So really, there's nothing that you can do with microcephaly anyway. So whether you have microcephaly or severe microcephaly, it doesn't really make a huge difference. It will in terms of childhood development and neurologic development, but there's really nothing that anyone can do once you fall into that category. Next, we have schizencephaly. So this is when we have abnormalities in the cerebral tissue. So we see sort of these clefts or these little like pockets that result from abnormalities on a very cellular level. So basically, our neurons develop in these particular pathways and in these particular patterns in our cerebral tissue. If we have a variation in the way that those neurons are developed in the pathway that they travel, that's when we're going to sort of get these different kind of like detours in the cerebral tissue. So we're going to see sort of this like cleft, really is like the only word that we can use to describe it. Once we look at our picture on the next slide, we'll be able to see how prominent that is. Basically, this can extend from the ventricle all the way to the outer surface of the brain parenchyma. So it's going to kind of go from like the central brain where the lateral ventricles are all the way over to like the parietal bones. This does affect the neurons. So this is going to have an effect on the gray matter of the brain, the white matter of the brain, the function of the brain. So on that very biologic level, this is going to have complications because of that. On ultrasound, this can be unilateral or bilateral. It's also going to be associated with the absence of the CSP, the cavum septum pellucidum, and also the corpus callosum. So what is this going to look like? So here we have sort of this like oblique view, kind of like a sagittal coming into the baby's brain. We have sort of our midline skull right here, lateral ventricle, what should be a lateral ventricle, and then we have this like split all the way to the parietal bone on the side. So this right here is going to be unilateral schizencephaly. So it kind of helps to remember like schizencephaly, like that's like the weird word, right? It's got a Z in it, kind of like this picture. Like this picture is very pointy, right? So Z's are very pointy. These clefts are very pointy. I don't know if that's going to help you guys, but helps me. Now we have lissencephaly. So this is going to be a little bit different. This is when we have the absence of the normal peaks and valleys of the brain, right? We have the normal sulcus and the gyri. This is going to be when we don't have that. So we basically have a smooth brain surface. Now those peaks and those valleys of our brain tissue, like that's really important for our cognitive ability, right? That extends the surface area of our brain tissue, that extends the way that our brain can function, that kind of allows us to have those complicated functions and those faculties. So when we don't have that, we're going to have a lot of cognitive delay, cognitive lack of development. So again, this is not going to be something that we usually see isolated. This is going to be something that's part of a bigger problem, a bigger picture going on. On ultrasound, not really going to be able to see this until later on in the pregnancy. We don't really evaluate the surface of the brain tissue, but you are going to be able to see when that surface looks abnormal, when it looks too smooth, right? Our normal brain tissue, sometimes it's going to be a little bit hyperechoic in some areas, a little bit hypoechoic in some areas. It's going to provide shadowing in some areas. So when we don't see any of that, that's when we can say, this looks a little bit smooth and it shouldn't. So here we have lissencephaly. This is coming in from the mid-axial plane, so coming in from the side here. We can see our cerebral tissue is just really, really smooth. And we normally don't want to see that, right? We want to see some sort of like variation to it. Next, we have Dandy-Walker malformation. So this is one of those conditions that has a lot going on. So now we're kind of moving away from some of the kind of individual things that we can see, conditions that we can see, abnormalities that we can see, and now we're kind of coupling some things together for very common conditions. So Dandy-Walker malformation, this is when we have dilation of the fourth ventricle with dysgenesis or lack of development of the cerebral vermis. And then we also see the posterior fossa as really enlarged. So remember, posterior fossa, it's not just like one thing, right? It's three things. It's the cerebellum, it's the sternum magna, okay? So we want to make sure that we are aware of that anatomy. And then our fourth ventricle, this is going to be abnormally dilated. So when we learned about the development of the baby's brain and how we image the baby's brain, we kind of just said we don't really see the fourth ventricle unless there's something really wrong with it. Cystic dilation, if it's dilated, well then we need to say, okay, what are we working with? What else is going on? Now our cerebellar vermis, that's going to be kind of like the isthmus of the cerebellum. Right? We have the isthmus of the thyroid connecting the right and left thyroid. The cerebellar vermis is going to connect the hemispheres of the cerebellum, that middle kind of region right in the back of the baby's head. So Dandy-Walker malformation, we need to see posterior fossa cyst, right? That's going to indicate to us that, wait a minute, why am I seeing this like cystic region in the posterior fossa? That's because we have an enlarged fourth ventricle back there. Right? We're going to see absence of that cerebellar vermis. Could even see absence of the entire cerebellum with Dandy-Walker. We're also going to see, depending on how severe that dilation of the fourth ventricle is, we could see a backup of that dilation through the rest of the ventricular system. So what comes before the fourth ventricle? The third ventricle. What comes after the third ventricle? The laterals, right? So we could see ventriculomegaly in some of the other ventricles, even though we're mainly seeing it in the fourth. If we're seeing it in the fourth ventricle, if we're seeing abnormalities in that posterior fossa, we need to question Dandy-Walker. So we can see this, I I guess you can technically see this as early as 11 weeks. That's kind of like a textbook piece of information, but I don't think we're going to definitively diagnose that until a little bit later on. So maybe in that early second trimester. This is going to actually happen very early on. So kind of like holoprosencephaly, where we said it's that abnormality of those very primitive brain structures in segments, this is also going to happen early on, right? If we all of a sudden, like, you can't develop a cerebellum and then all of a sudden it goes away, right? So you can't develop the cerebellar vermis and then have it go away. So this is going to happen very, very early before all of those structures can develop properly. So here, Dandy Walker, we can see that posterior fossa is very dilated, right? So we're not really seeing that normal kind of bean-shaped cerebellum. We're not really seeing the cisterna magna. We're not really seeing like the nuchal fold at the back of the baby's head. So this is all dilated posterior fossa. Now, if you look closely, this is cerebellum and this is cerebellum, and they're not attached. So we do not have the cerebellar vermis. Now, if we also look at that posterior fossa dilation, we see it kind of comes in between those two pieces of the cerebellum, right? That's it extending from the fourth ventricle. So this is technically going to be our fourth ventricle with all of that dilation that is kind of producing this enlarged and dilated posterior fossa. Next, we have agenesis of the corpus callosum. It's exactly what it says. So we don't have the presence of that callosal tissue. So it just completely fails to develop. Our corpus callosum, as we know, is how the two cerebral hemispheres communicate with each other. So, I mean, that's going to kind of produce some problems, right? We're typically not going to see this as an isolated finding. We're going to see this associated with something else going on. This is usually going to be caused by, again, some sort of infection into the baby, inflammation into the baby. So we have an abnormality with their vascular supply, and for some reason that corpus callosum just did not develop or did not fully develop to communicate between the two cerebral hemispheres. So on ultrasound, we are just not going to see that band of tissue crossing between the two cerebral hemispheres. We're also depending on the severity, maybe not going to see the cavum septum pellucidum. We could see dilation of the third ventricle. That third ventricle could actually start to move upward because the corpus callosum is not there. So it's going to kind of migrate upward. And the ventricles may start to change their shape as well. So they're going to have a little bit more of a pointy teardrop shape. Now, this is something that we don't routinely document the corpus callosum in OB. So this is going to be something that our patient had genetic testing. It came back abnormal. We need to get some more advanced images of the baby's brain development. So this may be something that we have to intentionally be aware of prior to performing an exam on that patient. And of course, if you see, the abnormality of the ventricles, well, then you can kind of question and move forward with that. But if we don't really see that severity with the absence of the CSP and the teardrop shape ventricles, then you may not think to question the agenesis of the corpus callosum. So now on the right-hand side, we have our corpus callosum kind of surrounding that third ventricle, right? Nice and pretty. Kind of like an elastic band right around it, and we don't have that on this left-hand side. So kind of see portion of third ventricle, but we don't really see that linear hyperechoic band surrounding it and going around it, right? Next, we have aqueductal stenosis. So basically, there is some sort of blockage throughout the pathways of the ventricular system. So this is going to be a cause of ventriculomegaly. Like we said, ventriculomegaly can kind of be an isolated finding, and if that brain starts to expand because of all of that backup of fluid, that's when we're going to fall into the hydrocephalus category. But basically, aqueductal stenosis is just some reason that duct is blocked in the ventricular system. It could be an obstruction. It could be an abnormally narrow pathway. It could be a stenosis. This is mainly going to happen in the aqueduct of Sylvius. So this is going to happen between the lateral and the third ventricle. Usually the fourth ventricle will be okay. And again, if we see an abnormally dilated fourth ventricle, we're going to question Dandy-Walker malformation because we know that that has to do with the posterior fossa. Ventriculomegaly and hydrocephalus, it's really going to be prominent in the lateral and the third ventricle. And that is because aqueductal stenosis, blockage in that aqueduct of Sylvius is going to be a little bit more common in that area. Next, we have vein of Galen aneurysm. So this is, again, not something that we are doing routinely. This is something that you kind of need to be aware of. And if we see any sort of abnormally cystic area in the brain, what is the first thing that we are going to do? We're going to say, can I put color on it? Okay, if you put color on it and it lights up like a Christmas tree, well, now you know we're dealing with something vascular. So this is going to be one of the more common vascular conditions that we see in the baby's brain. This is also known as the vein of Galen malformation. This is a rare type of AVM. So AVMs, arteriovenous malformation. This means that they don't go through the normal pathway of communication between an artery and a vein, right? We know our arteries supply. They drain into our capillary tissues, capillary beds, and then they, right, our arteries go to arterioles, into the capillaries, into the venules, into the veins. That's normal. That's not happening with an AVM. AVM is arteries going right to vein. So we're not getting this normal exchange of blood flow that we should. So now when we see this, our vein is going to be enlarged and it's going to communicate with the normal appearing arteries. This is going to be kind of an isolated incidence. This is going to have a male predominance or male prevalence. Male babies are a little bit more susceptible to this. It is, like we said, going to be pretty isolated, but we can sometimes see this with other cardiovascular conditions going on. So baby could have heart defects. Not common to see this with a vein of Galen aneurysm, but they could have cystic hygromas, which we'll talk about, and then hydrops. If we do happen to see those other conditions, that's pretty poor prognosis. It's almost better if we don't, if it's kind of an isolated, sporadic finding. It can be associated with neurological damage. So if our artery and our vein is not, they're not playing nice with each other in the brain, they're not communicating the way that they should, it's going to lead to lack of oxygen to the brain. That tissue is going to die. It's going to have lack of blood flow. We could even bleed out. And it could get so big that it starts to compress the normal brain parenchyma nearby, and then that tissue can't work properly because of it. On ultrasound, like we said, we're going to see a cystic area in the middle of that baby's brain. When we put color on, it's going to confirm that it's vascular. We know that that's most likely going to be some sort of vein of Galen aneurysm or malformation. Here we go, classic cystic picture, left-hand side, put color on it. Okay, we see this ebb and flow, this to and fro sort of vascular appearance, right? We have venous supply fighting with arterial supply. Next, we have choroid plexus cysts. So these are usually fine. They're totally normal, kind of like a benign finding. They usually go away on their own. It's basically just a cyst in the choroid plexus. Can be round, look just like a regular cyst. They're going to contain cerebral spinal fluid, so they are still going to be anechoic. It's really not going to be associated with anything overwhelmingly concerning. They can be associated with aneuploidy, but these patients typically know that they're at a higher risk for fetal abnormalities or fetal chromosomal problems. Aneuploidy is just talking about the general term for abnormal genetic makeup. We'll kind of specify that a little bit further in a different lecture. These are usually going to go away by that second to maybe early third trimester, 22 to 26 weeks. Ultrasound, it's going to look just like a regular old cyst. And here we go, nice and easy. Next, we have porencephalic cysts, also known as porencephaly, not to be confused with holoprosencephaly. So sometimes those terms can get confused. Porencephalic cyst, this is going to be when we kind of see another cystic-like mass in the baby's brain, but we go to put color on it and it doesn't light up like a Christmas tree. And it's not a choroid plexus cyst. It's in that tissue. It's in that cerebral tissue. So okay, well, what is this? Like, why are we getting a cyst in that region? So basically, we have these cerebral spinal fluid cysts that communicate with the ventricular system or the subarachnoid space. So when we remember from our ventricular slide, the subarachnoid space is kind of like one of the last places that the CSF goes out to, right? So it kind of gets trapped in these layers of the brain tissue. and it kind of results in this collection of CSF. It can result from a hemorrhage, an infarction, trauma delivery, right? So we may even see this after the baby's born, intrauterine inflammation or infection. So again, that inflammation and infection, exposure to viruses, very, very severe for the pregnant mom. Our brain tissue is actually going to so this very particular portion or section of brain tissue is going to undergo necrosis for whatever reason it may be listed above. The brain tissue is going to be reabsorbed and a cystic lesion remains. What does that kind of sound like? Hydranencephaly, right? We have some sort of vascular problem. Our tissue dies off and it gets reabsorbed and replaced with CSF. So this is going to be a less worrisome, less severe type of brain tissue necrosis. And it's usually going to be isolated in that region where the cyst is. Not going to be associated with anomalies. Again, it's only going to be caused by one of those indications listed. On ultrasound, we are going to see a cyst within that brain tissue, particularly within the brain cerebral section. We can see communication of the cyst with the ventricle if that's where it is originating from. So we can kind of see it extending out from the lateral ventricle, not to be confused with schizencephaly. Schizencephaly is going to be that cleft, right? That sharp point that comes from the lateral ventricle over to the outer side of the baby's brain. This is going to be more cystic in its shape, but it may not be that perfectly round cyst that we're used to seeing. So here, picture on the left-hand side, see how that's not like the perfectly round cyst that we're used to seeing like maybe in the liver? That's because it's coming from this portion of the lateral ventricle. Okay, and again, schizencephaly is going to be that cleft, that sharp point coming from the lateral ventricle outward. And then this is the 3D image. This is protruding out from the lateral ventricle. So picture yourself, if you're like in this baby's brain, you are standing in the lateral ventricle and you are looking at the inside canals of both lateral ventricles. This is going to be a protrusion outward. See, it's kind of like rounded, still fluid filled. Next, we have Arnold-Chiari malformation. So get these names down. We have Dandy-Walker malformation. We have vein of Galen malformation. We have Arnold-Chiari malformation, not Budd-Chiari malformation. Okay, Arnold-Chiari malformation. This is when our cerebellum is really small, or it's kind of like moved backwards into the foramen magnum of the baby's skull and the cervical canal of the neck. On ultrasound, we're going to see what is known as the banana sign. So this is when we have that cerebellum and the fourth ventricle that are going to be placed really, really low. So we're not going to see them in that normal level of the posterior fossa. So here, what's one of the biggest things that sticks out to you guys as soon as you look at this picture? Hopefully it should. Scallop, right? Clover leaf skull. So like we said, craniosynostosis can be isolated, but that's usually not going to be the only thing going on with it. So Arnold-Chiari, abnormal cerebellum, abnormal fourth ventricle, kind of like Dandy-Walker, right? Dandy-Walker had to do with the fourth ventricle and the posterior fossa as well, but that had to do with that dilation, that cystic dilation of the fourth ventricle that then kind of produced those byproduct problems, right? We didn't have the cerebellar vermis. We don't have the normal posterior fossa. We don't have the normal cisterna magna. It's kind of just like all replaced by that dilated fourth ventricle. This is now saying, Arnold-Chiari is now saying, okay, my cerebellum is still not normal. My fourth ventricle is still not normal. My cisterna magna is still not normal, but why? It's all displaced. Right, so Arnold-Chiari, we're going to see the banana cerebellum. Look at this banana. It's literally curved way more than our cerebellum should be. Our cerebellum should be like this nice, pretty, kind of like the Peanut Man, right? And if you look at that guy, he's like all hunched over. That's going to be our banana cerebellum. Now, if we look behind it, now Arnold-Chiari doesn't have fourth ventricle dilation, so we're not going to see an enlarged fourth ventricle, but we don't have our cisterna magna. We have no fluid behind that cerebellum, right? There's nothing here. So this is saying, okay, something abnormal is going on. And then also, if we were to imagine this banana cerebellum wasn't written on here, we would be able to see that we would be very low in the baby's head. Usually our posterior fossa, we can kind of see our thalamus in the ballpark. We can kind of still see our lateral ventricles in the ballpark. We're not seeing any of that in this picture. So this means that for us to take this picture, for us to obtain this picture of this banana cerebellum, this abnormal cisterna magna, this means that we are way lower than we normally would be. Okay, so finishing off with our brain, and then we're going to move into our spine. Spine is very quick. We talked a little bit about skull shapes, right? We talked about the clover leaf. We talked of the clover leaf skull. We talked about the banana-shaped cerebellum. We talked about, we really didn't talk about any of these other ones yet. But there are other sorts of skull shapes that we can use to help aid in diagnosis. So the lemon skull. So this is when we have the abnormal fusion, right? We still have craniosynostosis of our frontal bones. So basically our frontal bones are going to appear flattened, and they're going to kind of scallop inward in the front of the baby's head. It's going to produce more of a lemon skull. See how it's kind of pointy at the front here? Banana sign, this is going to be our curved cerebellum, so not necessarily talking about the skull, but the cerebellum itself. We can also have a strawberry skull, so this is where we have a flattened occipital region, and then a point in frontal bone, back, front. And then we have brachycephalic and dolichocephalic. We already know about these. Brachycephalic is going to be a really short, broad, wide skull. Dolichocephalic, really long, narrow skull. Cloverleaf, we saw that with our craniosynostosis. And frontal bossing, when we get into some chromosomal abnormalities, genetic abnormalities, trisomies, all of those conditions, we're going to talk about frontal bossing. So basically, like, your skull's kind of shaped the right way. So if I'm doing like a sagittal profile picture here, here's like a normal baby's head, right? Frontal bossing would be like, whoa, your forehead comes way out. Okay, moving into our spine. So scoliosis and kyphosis, we have all heard of scoliosis, right? That's when somebody has an abnormally curved spine. We can have the abnormal curvature, any sort of angulation of curvature of the spine. It could be in any segment, and it's still going to fall into that scoliosis category. Most patients who have scoliosis is going to occur where the thorax meets the lumbar portion of the spine, and it very rarely can be associated with cranial abnormalities and severe lethal anomalies. When we get into some skeletal fetal anomalies, we're going to kind of learn about some lethal things that we really don't want to find on ultrasound. Also, evaluating scoliosis and kyphosis on ultrasound on a baby is like pretty impossible. So this is something that we would be able to see if we were to perform a spine ultrasound on a PD patient once they're born. But in utero, not really something that we're going to be doing. So scoliosis, abnormal curvature of the spine from side to side. Kyphosis, abnormal curvature of the spine front to back. So this is like little old lady syndrome, right? So sad. Next, we have spina bifida. So now this is very important. When we are taking our sagittal spine pictures, also our really all of our spine pictures, super important in ruling out spina bifida of any type. So basically, spina bifida occurs when our neural tube fails to close after 6 weeks. So when we learned about that, we learned that the middle portion of our spinal canal, or neural tube rather, closes first, and then it goes upper portion and then lower portion are going to close. Because the lower portion closes last, right, the lumbar portion of our spine, and the neural tube closes last, that's where we're going to see a lot of abnormalities occur in that lower lumbar region because of that. It failed to close after that gestational checkpoint. This can be caused by folic acid deficit, so mom's not taking her vitamins, mom's not practicing a good diet, could also just be genetics, could run in the family. The mom could have diabetes as well. Diabetes is awful. Maternal diabetes, whether it's type 1, type 2, it wreaks havoc on a pregnancy. And you are immediately a high-risk pregnancy, regardless if it's type 1 or type 2. And also trisomy 18, which we will learn about. Cranial signs of spina bifida. So although this is occurring in the spine, it can have an effect on how the brain develops. So we could see the lemon sign, so the scalloping of the frontal bones of the skull, and then we could also see the banana sign, so we have that curved cerebellum. On ultrasound, we're going to see spinal irregularities, typically in the lumbar region. We're going to see bulging of the skin at that region of where this is occurring. We are also going to look to see, okay, what does that bulge contain? Does it contain fluid? Does it contain echogenicity? Does it contain solid tissue? Depending on what that bulge and that herniation contains, that's when we're going to have different types of spina bifida. So what are our different types? It's also important for us to make sure that we are documenting the precise level and size of where this is occurring. So different types. We have spina bifida occulta. We then fall into meningoceles and meningomyoceles. So spina bifida occulta, this is not super concerning. But basically, this is not going to be something that is overwhelmingly like sensitive in terms of what is coming out. Basically, we have this little patch of skin in the back of the baby's lumbar region. It's kind of like this little dimple, this little like bulge and cleft of the skin. Sometimes it can be like super hairy. It's like a really random like hairy patch. I don't know if that's the body's way of like giving it extra protection because it knows something happened in that region, but sometimes they're just really hairy in that one little random patch. This is when we have normal cord, our nerves and neurological development are normal, and all we see is a little bulge. So we have a diagram on the next slide of what that's going to look like. So you're like, basically nothing is coming out. And in a sense, that is true. We then have a meningocele. So this is when just the meninges are coming out. So just those protective layers of the spinal cord are coming out. Not just, but we don't have all of it coming out yet. Now, when we have a myelomeningocele or a meningomyelocele, this is when we have both coming out. The meninges and the spinal cord are coming out. So, of course, those are going to be way more severe and way more serious. Now, normal spine, right here, we're actually going to learn about how we can perform pediatric spine exams in the spring. But for right now, here we have our sacrum, sacral bones. We have our lumbar bones, posterior lumbar bones, lumbar vertebrae. We have our spinal cord coming down the middle. Then you see all like these little like fibers, right? That's going to be our conus medullaris, right where it ends, right where it tapers. It's going to be our conus medullaris. Now, that's all normal. When we go to occulta, okay, we have like this little variation between those lumbar vertebrae, right? Those posterior lumbar vertebrae, and it allows for a little bit of a bulge in the skin. So it's saying, hey, I'm not like, nothing's like sneaking out quite yet. Like I'm not like herniating quite yet, but I'm just gonna like draw your attention that maybe I need a little extra protection in this area. Like maybe we wanna kind of just like check this area out. Then when we have a meningocele, okay, well, we have that abnormality in the vertebrae, right? And we have the meninges coming out, cystic, because it's just going to be that cerebrospinal fluid. And when we have a myelomeningocele or a meningomyelocele, we have the meninges coming out and also that conus medullaris, that spinal cord fibers coming out as well. Of course, these two are going to be extremely concerning, can affect the way that the patient walks and develops. We don't want to mess around with the spinal cord. Next, we have caudal regression syndrome, also known as serenomelia. This is extreme. Both of these are going to be extremely rare. They're similar and slight differences between the two. They kind of fall in the same ballpark of diagnosis. Caudal regression syndrome, this is going to kind of have a range of conditions that go with it. So this is basically saying like when the caudal end of our neural tube was developing, it kind of just like stopped. So it regressed. Caudal regression syndrome. Caudal means lower end, right? Lower half. When we have serenomelia, this is when we actually have fusion of the lower extremities. This is an extreme form of caudal regression syndrome, but kind of its own separate disorder, so a little bit more particular in the diagnosis. It can be caused by arterial insufficiency to those lower legs, and it's usually going to be fatal, although there are some stipulations to that. Male babies also are unfortunately at a higher risk for this by 3 to 1. With caudal regression syndrome, we're going to see the sacrum kind of degenerate. So we're not going to see that prominent triangular sacral bone. We're going to see talipes of the foot, so that abnormal version of the foot. We'll talk about that a little bit more as well. We're going to see abnormal lumbar vertebrae, pelvic abnormalities, decreased movement of the lower limbs and extremities. So really, it's going to kind of just vary on how this condition affects this baby in terms of what it looks like. And then serenomelia, we're going to see the fused lower legs. We're also going to see bilateral renal agenesis, and that's really why this is going to be a fatal condition. So if that baby does have fused legs, missing kidneys, not really going to survive. If they happen to have a kidney, that's great news. They can, you know, kind of, we can figure it out after the fact. Also, they're going to have oligohydramnia, so they're really not going to have enough amniotic fluid, and that's usually because they don't have their kidneys to produce the fluid, and they're usually going to have a single umbilical artery as well. So now, this is probably before your time, but TLC used to have a show with the girl on the left-hand side. It was called a Mermaid Girl, and I think her name was Shiloh, and she has serenomelia, and she was one of like the only patients who like actually lived and thrived with this. I think she only lived to be about like 9, I want to say. I don't really remember the details, but you can see like her legs are fused. Like there's no mistaking that. Like that, I mean, that's why they called her Mermaid Girl. So she has serenomelia, and she was one of those extremely rare cases that was able to survive. Picture on the right-hand side. So this is going to be sort of the classic overarching diagnosis of caudal regression syndrome. You can see the top half of her body is like normally developed, and then the lower half of her body is severely underdeveloped. So her pelvis is abnormally small, her lower extremities are abnormally small. So kind of just that classic overarching diagnosis. Next, we have a sacrococcygeal teratoma. We've learned about teratomas. So basically, when we get one of those, located right between our sacrum and our coccyx. This is going to be the most common congenital tumor in neonates, so this is something that we can see quite a bit of, and we want to make sure that, again, when we're taking those spine pictures, we're not missing this. This is going to hang right off that baby's butt, so the coccyx is always going to be involved in these. Sacrococcygeal, sacrum, coccyx, always going to involve the sacrum, always going to involve the coccyx. So this is something that's really going to hang off right the bottom of that baby's bum. It's going to contain all 3 primitive germ layers. In terms of what the teratoma is made up of, female babies more likely to have this. On ultrasound, we're going to see a mass coming right off of that baby's bottom. It could be solid, complex, calx. You know, teratomas have a range and a variety of appearances. And then we also have a functional AV fistula. So sometimes it can affect the vascular supply of the baby's lower legs, can also affect the baby's bowel movements. So we could have an anal fistula as well with these babies. So something that we need to be aware of, especially when we're diagnosing this in utero, because this is something that we can plan for shortly after birth. So healthy baby, normal kind of back to bottom relationship. And then we have a sacrococcygeal teratoma, that lower back, that sacrum portion, extending off of our coccyx, that really protruding mass, classic teratoma. So a lot of information on this slide. A lot of this information we are going to come back to as we start to kind of piece together these different sectional abnormalities. So next module, I believe we're going to start talking about the neck and thorax. So we're going to kind of walk our way down the baby's body. And then we'll be able to kind of piece everything together once we kind of wrap it up with trisomies and all of the other genetic conditions that are very common in the OB world.